So why are we doing this? Well, we all know that lots of care can be very fragmented, and that we should really be looking at how we can join care up better. We know that when care is very fragmented, this can often be disempowering for patients. It can often be quite frightening for patients. They may not know where to go to ask for help or who to ask. And this, in turn, we know leads to increased use of urgent and emergency care services, as well as increasing hospital admissions. So knowing this, there was a document published called Transforming Primary Care in London, a Strategic Commissioning Framework. It was a very catchy, snappy title, and there's lots of very clever, complicated things in this document. But essentially what it describes is the 5 key elements that are important in coordinating and joining care up better. And these things have affectionately become known as the 5 Cs. And what they include is case finding and review. So this is essentially identifying the group of patients that we need to concentrate on, or who would benefit most from this approach. Having a named professional is a second thing. Having a care plan is a third thing. The fourth thing is how we support patients to manage their own condition, because they, of course, are the experts in their condition. And the fifth thing is multidisciplinary working, so making sure that we're bringing together the right people across the system. So, in light of knowing what these 5 essential elements were, we then set about developing our own version of this in Southwark. And we knew that for this to work, it had to be absolutely and robustly co-designed with clinicians, and I'll talk about that in a while. And it also needs to be robustly co-designed with patients. And the patient engagement part of this was very much a joint endeavour across all the engagement leads, across all of our LCN organisations, really led by Rosemary and the CCG. And Rosemary will talk a little bit more about that. So the clinical engagement. So the clinical engagement was quite extensive. It spanned a timescale of probably just over a year. We used lots of different things. We had 4 clinical learning events where we used our PLT time, which is our protected learning time events, which is where lots of GPs come together, and we covered all sorts of different elements. So how can we improve care? What's working locally? Where are the gaps? We talked about motivational interviewing, behaviour change. We also took work back into our practices and did work at practice level, looking at what our cohort of patients were, who was in the cohort, what could we do better as a practice team. And then finally, we realised that quite literally the best thing to do was lock everybody in a room for a day and not let them out until they'd come up with a pathway. And that is what we did, and we called that the hackathon, and it was surprisingly productive. I think everybody probably just wanted to go home, so they got on with it. Rosemary.
So in parallel to the clinical engagement, we also ran a series of patient engagement. And being a clinical commission group leading the engagement process, clearly we don't have our own patients. So the GP federations wrote out to 1,800 patients across North and South Southwark using a letter that had been developed by the engagement leads and Healthwatch. So it was in everyday English and trying not to use NHS jargon. So from that, we got 120 patients who contacted us, and we followed them all up. And to be honest, quite a lot of people were just quite surprised to get a letter in everyday language from their GP, so that was quite telling in itself. We worked with Healthwatch Southwark and a local organisation called Revealing Reality, who trained us up in using ethnographic approaches, and we went to and visited maybe 30 of the people who'd got in contact with us to take their stories at home. We also offered people the opportunity to come to a workshop. I'm just going to move us on to we made some films of the patient stories as well. So I think there's a sound issue now. So we're going to play you a clip of a film.
So it's basically,
we're not quite.
I think, a combination heart and diabetes are causing all my problems. But I get a lot of pain in my legs and my feet. Pretty much in pain all the time with my legs and my feet. Over a year, I don't know, 50, 60 appointments. over a year. I take a lot of tablets. I don't know, 25 a day, something like that. I remember one day, I think it was when my second heart attack, and I had about 8 or 9 doctors around my bed, and they was all like talking about my condition, but the actual doctor that I'd seen before then wasn't there. When I'm with the doctor, I very rarely ask questions. I just sit there and go, yeah, okay, bye-bye. I don't go, but what about this and what about that, and should I do this and should I do that? They're the professionals, so let them sort it out. I expect them to go through all these medical, technical terms with me, because I wouldn't understand what they were saying anyway. You know, like say these letters that you get when you've been to an hospital, but it might well be in Chinese, for example, so I don't understand any of it. But my wife will sit and read it, you know, and she'll go, you know, she'll look at something and go online and try to keep on top of it that way. But she's got her own health problems as well, so, you know, I don't expect her to do too much.
So that we've got a few more films from people living with multiple long-term conditions on our YouTube channel as well. This is another way we wrote up some stories as well. So this is, oh, have I skipped on one? Sorry, I have. This really doesn't do justice to the rich patient stories that we've had. Is that 2 minutes? So I'm going to skip over that. Interestingly, just some of the things, because we talked to people in their own homes, we got so much information. So Azra lives with her 3 sons, so no one would have thought that she's lonely or isolated. But she is. Her life, she lives downstairs, her life is reduced to her bedroom and her kitchen. What was interesting about Azra is that the best time that she had was when she came out of hospital, because she had female care workers in her own home talking her own language with her and having a laugh. So we used all this information and we brought people together in a workshop. And given that we were trying to look at planning or getting the patient experience into care coordination and care planning processes, and no one had heard of a care plan, we wanted to make it meaningful for people. So we used visuals, we had a big picture on the day, we had photographs from people's homes. We tried not to talk about care planning or NHS stuff until after the exercise, which was a roots and fruits exercise. The fruits were what's important to people's lives, and the roots were what do people need in place to help them achieve that. And so that was tabletop exercises that we did. What was really important, what came out of that so strongly, is that people want to carry on what they were doing before they became ill, unsurprisingly. They don't want to be seen as a collection of conditions from their medical practitioner. We were joined in the afternoon by colleagues from across the local care network organisations, so adult social care, GPs, nurses, pharmacists, community health services and voluntary sector, and colleagues from acute hospitals. So they could hear what patients had said in the morning and look at what we needed to do together to put into place a good care planning process. So just moving rapidly on. We then in parallel tested what came out of the working groups that had been set up with focus groups of patients. The care pathway was launched in October last year, and Healthwatch are currently visiting people at home who've started going through this pathway to understand their experience of it, to take part in a broader evaluation.
Perfect. Thank you.
Thank you.
Thank you.